rest of it. Guntur is not there. So Mohan Rao Patibandla will talk on intraventricular tumor resection using BrainPath and Parafascicular approach.
Good morning to the respected chairpersons and my dear colleagues. This is I'm talking about the minimal invasive neurosurgery here. This is my OT and biplane cath lab. This is a hybrid operation theater with 4K endoscopy. So my talk is brain path assisted intraventricular tumors. Experience of 51 cases. So in all these deep-seated tumors, the white matter tracts are getting damaged, or either by the retraction injury or through the coagulation. I mean, by the cautery. So using these brain path like endoports or brain ports may be helpful in dispersing the white matter and reaching safely the target. So these are almost like 2 to 7% of the intracranial tumors. Retraction injury is the problem in the traditional transcallosal or transcortical, and brain path assisted neuronavigation might be the one of the alternative. As you know, all the minimally invasive neurosurgeries have several advantages. That is increased safety, more precision in performance because we use more gadgets, less pain, faster recovery, less injury to the tissue, and less scarring. So my objective of this study is to evaluate the safety, efficacy, and outcomes of the brain path. So we started the hospital in 2019. So from that time to 2024, we did this. And tumor locations in all the ventricles, anything that is within 10 mm distance to the ventricle is considered as a intraventricular. So the surgical techniques are like endoport is necessarily used in this. Either endoscope, exoscope, or microscope was used. DTA in the MRI for the trajectory planning for the anatomical, and data analyzed was the extent of resection, complications, and clinical outcomes. So the basic things what we need is here I am showing the tracts. So first we will identify the tracts, and then we'll use that through the navigation, and then we'll use these tubular retractors, so they will disperse the pressure yeah, sequentially instead of the rectangular retractors. And then we use either exoscope, microscope, or endoscope for the good optics, and then Q size, and then neuro monitoring, especially subcortical mapping is almost inevitable in all these cases if it is needed to the eloquent fibers. And then so, this okay. So this is one of the tumor I would like to show you. Um, is is the thalamic tumor, basically the intraventricular part. So we mapped out, and here it seems like here the cortical tract is there. So we came all the way from the lateral, anterolateral, and then we removed this. So I'll show you just, so this is the planning. Everything is planning. And then this very small craniotomy of 2 centimeters, 2 into 2. And the tube is around 13 mm. And then we place the tube through the navigation, along with the navigation, we'll place inside. So at the end, the tube will be like this in the where the tumor is there. Then we will take the biopsy with this, and then the CUSA, and then um, so so this is the final. So it's not working. Touch is not working. Yeah, this is a total remove. Total removal. So so this is the exoscope. This is with the endoscope, and these are the some of the tumors. This is the metastasis, and this is the posterior thalamic intraventricular meningiomas. And these are some of the tumors. So when it comes to this, the total 51 cases, age is around 35, and males are more. Presenting symptoms are as usual. Headache is the most common, and visual disturbances is the next. Duration of the symptoms is around 10 weeks. Um, Tumor location more in the lateral ventricles. Mean tumor size is around 3 centimeters. Histological diagnosis, most of them are colloid cyst, next followed by the ependymoma, central neurocytoma, glioma, meningioma, choroid plexus. Approach is the same, and mean operative time is around 150 minutes. Mean blood loss is around 90 ml. And extent of resection is almost 45 cases. So we did the gross total resection. Post-op complications, three patients has a transient hemiparesis and recovered within 3 months, and short-term memory loss in one patient. Mean hospital stay is around 4 days, and recurrence in the subtotal resections. So when comes by the outcome, all these gliomas, especially the ependymoma, central neurocytoma, and astrocytomas, they caused the complications, whatever the complications we have. And when it comes to the endoscopic and exoscopic or microscopic, endoscope shows less operative time, less blood loss, and gross total resection. But gross total resection is not a significant one. But mean operative time and mean blood loss were less in endoscopic cases. So overall, the study 51 cases, mean age is 35, male to female 29 to 22, tumor location lateral almost like 60%, and the third 15, and fourth mean operative time 150, mean blood loss is 93. So the limitations of study is limited by the even though it's a prospective data collection, retrospective design, and a single center experience. However, the homogeneity of the technique and surgical expertise enhances the internal validity. So BrainPath is useful as a minimally invasive tool, which is good in removing, and it almost less blood loss and more efficiency. Thank you.
Thank you, Dr. Mondo. Any quick question or comment?
This is a portal system, right? The endoport you use.
Yes,
So
sir.
in some cases you have to convert to the open case.
No.
In all
It is almost like whatever with the microscope or whatever we do, this is the 13 port. It's not 7 endo port. It's a 13 port that is designed for the blood removal initially, and after that it was changed to the tumors. So never used to change. Whatever the corridor is needed, only we need 1 centimeter corridor.
And how do you decide in which cases you will open it and in which cases you are going to use the endoport?
So this port always I use anything that is more than 3 or 4 centimeters inside. So if it is a deep seated, then we use this.
And if the tumor is quite large size, even then you use it?
Yes, even 6 centimeters size of the tumors also we can, because it will move.
So not just for intraventricular, even for deep-seated
Yes, sir.
parenchymal, you use it.
Yes, sir.
And in cases where you need to do mapping subcortically,
Yes.
you are able to manage that.
Yes, sir. All the cases I do the subcortical mapping. In these
Okay.
48 cases were used IONM. So with the suction we do with the suction only we do that.
Okay. Okay. All
Thank
right.
you.
Thank you very much.